Greetings to my lecturer, Miss Rafida Binti Super. My name is Nur Asmina Binti Muhammad Repin, ID student 202-428-0496. This is my video presentation for Digital Skill Assessment for Code MRD 444, Radiographic Image Evaluation of Elbow AP. This is the list of contents in this presentation. It consists of radiographic anatomy, positioning criteria, exposure criteria, and radiographic image evaluation using Paceman method. Paceman is a method used to critique the radiograph whether to reject or accept the radiograph. It consists of important points to be looked at. P is for positioning and projection. A is for alignment. C is for collimation. E is for exposure factor. M is for marker. A is for aesthetic, and lastly, N is for name or patient's ID.
Starting with the radiographic anatomy. This is the anatomy and the radiographic image of an elbow of AP projection. On the left diagram, the anatomy of the elbow shows humerus, coronoid and radial fossa, medial and lateral epicondyles, capitulum, trochlea, trochlea sulcus, head of radius, and ulna. On the right diagram is the elbow AP radiograph. In this radiograph, we can see humerus, olecranon fossa, medial and lateral epicondyles, coronoid, medial trochlea, radial head, radial tuberosity, radial neck, capitulum radius joint, radius and ulna. In elbow AP projection, we will focus on detecting rotation and detecting flexion of the elbow to determine whether the positioning of the elbow for this AP projection is correct or not. In detecting elbow rotation, we evaluate the radial head and tuberosity superimposition of the ulna. The elbow has no rotation. If the radial head and tuberosity is seen superimposed at lateral aspect of proximal ulna by 0.6 centimeters, and the medial and lateral epicondyles are demonstrated in profile. If the radial head and tuberosity are superimposed at lateral aspect with proximal ulna more than 0.6 centimeters, it indicates that the elbow is internally rotated. And if the radial head and tuberosity are superimposed at lateral aspect with proximal ulna less than 0.6 centimeters, it indicates that the elbow is externally rotated. This is the correct positioning of no elbow rotation. We can see that the radial head and tuberosity is superimposed at lateral aspect of proximal ulna by 0.6 centimeters, and the medial and lateral epicondyles are seen in profile. Therefore, no improvement needed for correct positioning. This is the incorrect position of the elbow, which shows the internal and external rotation of the elbow. The left diagram showing the radial head and tuberosity is superimposed at lateral aspect of proximal ulna, more than 0.6 centimeters, indicating the elbow is internally rotated, and the medial and lateral epicondyle are not seen in profile. To improve, rotate the elbow externally until humeral epicondyle are parallel with image receptor IR. Next, the second diagram shows the radial head and tuberosity is superimposed at lateral aspect of the proximal ulna less than 0.6 centimeters, indicating the elbow is externally rotated, and the medial and lateral epicondyles are seen in profile. To improve, rotate the elbow internally until humeral epicondyle are parallel with IR. Next, we detect the elbow flexion. In detecting elbow flexion, we evaluate the distortion of proximal humerus or distal radius and ulna. The elbow has no flexion when the capitulum radius joint is opened. The olecranon process is within the olecranon fossa, and the coronoid is demonstrated on end and radial tuberosity is seen in profile. In detecting the flexion of an elbow, if the proximal humerus is foreshortened, it indicates that the humerus is elevated. And if the distal radius and ulna is foreshortened, it indicates the distal radius and ulna is elevated. This is the correct positioning of no elbow flexion. Based on the radiograph, we can see the capitulum radius joint is opened. Olecranon process is within the olecranon fossa. Coronoid is demonstrated on end and radial tuberosity is seen in profile. And no elevation of humerus or distal radius and ulna. This indicates that the elbow is fully extended. Therefore, no improvement is needed. Here is the incorrect positioning, showing the elbow has flexion. The first diagram on the left shows the proximal humerus is foreshortened, which indicates the humerus is elevated. The distal radius and ulna is parallel to the IR. We can see the capitulum radius joint is opened, and the olecranon process is within the olecranon fossa. To improve the positioning, fully extend the elbow and rotate the humerus until it is parallel with IR. The diagram on the right shows the distal radius and ulna is foreshortened, which indicates the distal radius and ulna is elevated. The humerus is parallel with IR. We can see the capitulum radius joint is closed, and the olecranon process is not within the olecranon fossa. To improve, fully extend the elbow and rotate the radius and ulna until it is parallel with IR. Moving on with the exposure criteria, where we evaluate the contrast, KVP, and density, MAS, of the radiograph. For elbow radiographs to evaluate the contrast, we see the thin structure which is BCO of lateral or medial epicondyles, and the thick structure which is BCO of olecranon. To evaluate the density, we see the thin structure which is BTP of lateral or medial epicondyles, and the thick structure which is BTP of olecranon. For example, for this radiograph, we can see the BCO of thin structure, which is lateral or medial epicondyles, and the BCO of thick structure, which is olecranon. This means that the KVP used is adequate for penetration and radiographic contrast. We also can see the BTP of thin structure, which is lateral or medial epicondyles, and the BTP of thick structure, which is olecranon. This means that the MAS used is adequate for detail and density. This means that both KVP and MAS used are adequate. So, no improvement is needed for the exposure factors. There are also other scenarios of exposure criteria, where the radiograph could be overexposed, underexposed, overpenetrated or underpenetrated. For this radiograph, by evaluating the density of the radiograph, the BTP of thin structure, which is lateral or medial epicondyles, cannot be seen, while the BTP of thick structure, which is olecranon, can be seen. And this indicates the radiograph is overexposed. This means there are too many X-ray photons reaching the IR. So, the density is dark and the bony trabeculae pattern of thin structure cannot be seen clearly. To improve, decrease the MAS by half. Moving on with another radiograph. By evaluating the contrast of this radiograph, the BCO of thin structure, which is lateral or medial epicondyles, cannot be seen. And the BCO of thick structure, which is olecranon, can be seen. This means the radiograph is overpenetrated, and there is too much KVP used. The bony cortical outline of thin structure cannot be seen clearly. To improve, decrease the KVP by 15%. Next is an underexposed radiograph. By evaluating the density of radiograph, the BTP of thin structure, which is lateral or medial epicondyle, can be seen, whereas the BTP of thick structure, which is olecranon, cannot be seen. This indicates that there are less X-ray photons reaching the IR, and the radiograph is underexposed. To improve, double the MAS by 2. Lastly is the underpenetrated radiograph. By evaluating the contrast of the radiograph where the BCO of thin structure, which is lateral or medial epicondyles, can be seen, whereas the BCO of thick structure, which is olecranon, cannot be seen. This is because there is not enough KVP used. So, the bony cortical outline of thick structure cannot be seen clearly. To improve, increase the KVP by 15%. Now, we move to the radiographic image evaluation using Paceman method. First is the projection, based on the radiograph shown. This is the radiograph of AP, projection of an elbow. This is elbow, because the elbow joint is at the center collimated field, and includes 1/3 of proximal radius and ulnar and distal humerus. Next, the radial tuberosity is in profile medially. This is AP, projection, because the medial and lateral epicondyles are in profile. Next is the positioning. Based on the radiograph, the positioning for this projection is incorrect. By detecting the elbow rotation, the radial head and tuberosity is seen less than 0.6 centimeters superimposed with proximal ulna. This indicates that the elbow is externally rotated. To improve, rotate the elbow internally until the humeral epicondyle is parallel with IR. Next, by detecting the elbow flexion, the capitulum radius joint is closed. The olecranon process is not within olecranon fossa, and the distal radius and ulna is foreshortened, which indicates the distal radius and ulna is elevated. To improve the positioning, fully extend the elbow and rotate the radius and ulna until it is parallel with IR. Next is the alignment. There are 3 components for alignment, which is the alignment between X-ray tube and cassette, the alignment between X-ray tube and patient, and the alignment between cassette and patient. Based on this radiograph, the alignment between X-ray tube and cassette cannot be determined, because there are no presence of 4 borders of collimation. Next, the alignment between X-ray tube and patient cannot be determined, because there are no presence of 4 borders of collimation. Next, the alignment between cassette and patient is incorrect, because the distance between the edges of film to central structure is unequal laterally. The centering point for this radiograph cannot be determined. The standard centering point for this projection is at mid-elbow joint, approximately 2 centimeters distal to the midpoint of a line between epicondyles. Moving on with the collimation. Collimation should be done to all 4 borders of the film. At superior borders, structures that should be included are distal 1/3 of the humerus. At lateral borders, Structures that should be included are lateral and medial epicondyles and skin borders. At inferior borders, structures that should be included are proximal 1/3 of radius and ulna. There is no evidence of radiation protection apparatus seen on the radiograph. Next part is the exposure factor. Based on the radiograph shown, by evaluating the contrast, the BCO of thin structure, which is lateral or medial epicondyles, can be seen, and the BCO of thick structure, which is olecranon, can be seen. By evaluating the density, the BTP of thin structure, which is medial or lateral epicondyles, are seen, and the BTP of thick structure, which is olecranon, can be seen. The KVP used is adequate for penetration and radiographic contrast, and the MAS used are adequate for detail and density. So, both KVP and MAs must be maintained. Next is the marker. Based on the radiograph, there is evidence of anatomical marker shown in the radiograph, correctly placed on the right, inferior side of the body, and placed appropriately, not superimposing, with any region of interest. Next is the aesthetic. The film size used is 24 by 30 cm, which is sufficient to demonstrate all structures of interest, and there is no evidence of artifacts seen in the radiograph. Last but not least is the name or patient's ID. Based on the radiograph, the patient's name, ID, date of examination, place of examination, and the radiographer's name are not visualized on the radiograph. After critiquing the radiograph based on Paceman method, we come to the conclusion whether to accept or reject the radiograph. This radiograph is unacceptable. This is because there is no evidence of the patient's name, ID, date and place of examination, and the radiographer's name on the radiograph, and the positioning for this projection is incorrect. This is the list of references used for this presentation. That is all for my presentation. Thank you so much for spending some time to watch this video. That's all from me, thank you.